A very good afternoon, dear delegates and respected faculty. Today, I will try to address the question that has been bothering all of us for the last few months. How do COVID-19 or SARS-CoV-2 and type 1 diabetes affect each other? Coronaviruses are not new to humans. Up to 20% of acute respiratory tract infections in children are caused by the commonly circulating coronaviruses. The first major outbreak of coronavirus, however, happened in 2002, known to us as SARS epidemic. The case fatality was significantly high in adults, reaching up to 17%. However, children seem to have fared much better. But a few years later, when the MERS epidemic happened, it proved to be a serious illness both for adults as well as children, with case fatality of 6% even in children. Coming to the current COVID-19 epidemic, the SARS-CoV-2, so far kids seem to be doing okay in terms of the severity of the illness, with almost next to zero case fatality in children. I recently conducted systematic analysis of 131 studies, including close to 8,000 children from across 26 countries, have seen that children often have milder symptoms and are less likely to be hospitalized when compared to adults. A very, very small subset, 0.14% of all these children manifested with severe inflammation, which has come to be known as MISC, the multisystem inflammatory syndrome in children. When the investigators looked at the underlying conditions of the affected children, close to 35.6% of all the children infected had underlying conditions. However, only 5 of 8,000 had endocrine or metabolic conditions. So with or without underlying conditions, kids seem to be having milder course of illness as far as SARS-CoV-2 is concerned. In the next 20 minutes, I would try to answer 3 questions, trying to explore the bidirectional dynamic between COVID-19 and type 1 diabetes. Can a pre-existing type 1 diabetes increase the risk of COVID-19 infection? Does an underlying type 1 diabetes increase mortality and morbidity from COVID-19? And can COVID-19 cause new onset hyperglycemia and diabetes? So let us look at if the risk of COVID-19 infection is increased by a pre-existing type 1 diabetes. Looking at the risk of infection in type 1s compared with general population, in this particular matched cohort study, you can see that the white circles are type 2 diabetes and the black circles are type 1 diabetes versus the controls depicted as the dotted line. The incidence rate ratio for infections is significantly high, both for type 1 as well as type 2, especially for men and between 40 to 50 years of age group. When the investigators looked at the association between glycemic control and the risk of infection, there was a significant association between increasing HbA1c levels and the incidence rate ratio of both outpatient-based infections as well as hospitalizations resulting from infections. And this is true both in younger age group between 40 to 64 years as well as beyond 65 years of age. And if we look at death rate resulting from infections, this is also significantly correlated with increased HbA1c, especially if the A1c is above 8.5%, both in as well as older age groups. So why do we see increased risk of infections in diabetes mellitus? When we look at diabetes, whether it is type 1 or type 2, it is a state of altered immune function. It's been shown that the T lymphocyte response as well as neutrophil function is quite a bit decreased in diabetes. And there are some associated underlying humoral immunity disorders as well as complement system deficiency. So all this put together makes the person with diabetes at high risk for infections. Does type 1 diabetes increase mortality and morbidity from COVID-19 illness? So there have been few studies looking at morbidity and mortality, both in type 1 and type 2. In a population-based study coming from UK, if you look at the deaths in 100,000 population, when compared with 27 in those without diabetes, the death rate was 138 in those with type 1 diabetes and 260 in those with type 2 diabetes. And as the age increases, the death rate seems to be exponentially increasing after the age of 50 years. The odds ratio for in-hospital COVID-19 related death is about 3.5 for type 1 diabetes and 2 for type 2 diabetes, and is significantly high in older age group. An interesting fact is that people under 40 years with either type of diabetes were at very low absolute risk of in-hospital death from COVID-19, which might indicate that underlying comorbidities resulting from older age group and having diabetes for a longer duration of time might have contributed significantly to the increased mortality. So the studies looking at risk factors identify HbA1c, higher HbA1c as a significant risk factor for mortality. A1C of 10% versus 6.5 to 7% seem to significantly increase the hazard ratio for mortality resulting from COVID-19. Now, the risk factors, as we have already seen, are older age, non-white ethnicity, and poor socioeconomic status, and of course, pre-existing comorbidities like previous cardiovascular disease or cerebrovascular disease or renal compromise. So what happens is that if you get a SARS-CoV-2 infection and a pre-existing poor metabolic control in patients with diabetes, especially those who are older, those who have underlying cardiovascular or cerebrovascular disease or renal disease, and those who have obesity, it can result in poor outcome. In addition, what has been shown that hyperglycemia can result in high IL-6 levels, interleukin-6 levels, and D-dimer levels, independent of other parameters, and can contribute to the pro-inflammatory and pro-coagulatory status of COVID-19 illness, ultimately resulting in poor outcome. And another multi-center study from USA looking at T1D in adults, it also confirms that the odds of being hospitalized increases tremendously with higher HbA1c values. And diabetic ketoacidosis seems to be a major reason for hospitalization because 50% of hospitalized patients had DKA. Coming to our third question, does COVID-19 lead to new onset hyperglycemia and diabetes? Let us quickly have a look at how diabetes happens, how diabetes could result from a viral insight. A virus can cause direct lysis of the islet cells by viral replication. If more than 90% of beta cells get destructed, you may have what is known as non-autoimmune fulminant type 1 diabetes or type 1B diabetes. However, if the virus results in chronic infection of beta cells with release of antigens, resulting in molecular mimicry and ultimately resulting in autoreactive CD8 T cells, it can lead to beta cell autoimmunity and chronic destruction in people who are genetically susceptible and leading to type 1 diabetes. The few existing reports or examples of fulminant type 1 diabetes, predominantly they come from Japan, especially in adults. This particular diabetes is preceded by minor upper respiratory or gastrointestinal infections, typically caused by Coxsackie, mumps, hepatitis A, influenza B, and parainfluenza. This fulminant T1D or T1B diabetes is characterized by significant diabetic ketoacidosis at presentation with very short duration of diabetes symptoms, often less than 1 week of symptoms, absence of any islet-related autoantibodies, and extremely low C-peptide levels, and associated elevated pancreatic enzyme levels. And most of the times, the HbA1c of less than 8.5% on the first visit. What happens in autoimmune beta cell destruction resulting from viruses? The evidence is predominantly existing for enteroviruses, though some evidence is existing for other viruses like Rota, herpes viridae, and rubella. Coming to our SARS coronavirus, can it cause islet cell damage? After the initial 2002 SARS epidemic, scientists have conducted studies to look at the port of entry for coronavirus, and they've identified a ACE2 angiotensin converting enzyme type 2 as a functional receptor of SARS-CoV-2. If the spike protein of SARS-CoV gets attached to the ACE2, it leads to finally the internalization of the coronavirus and the infection of the cells. A study from 72 human tissues confirmed that ACE2 expression is not limited to lungs and gastrointestinal system. However, it is expressed in other tissues like cardiovascular, renal tissues, and pancreas as well. So the expression in pancreas is significant and is often upregulated by inflammatory stress. And let us see what happened in 2002 in terms of SARS-CoV resulted beta cell damage. In a retrospective analysis, looking at clinical and biochemical characteristics of patients who passed away from SARS as well as the survivors of SARS, it has been shown that, it's been noted that, interestingly, even milder SARS pneumonitis without previous diabetes, those who did not receive any glucocorticoids still had higher fasting blood glucose levels. And pancreatic islets seem to be strongly immunopositive for ACE2 receptor, while exocrine tissues are only weakly positive. A follow-up study of this cohort, the investigators identified 164 patients who did not receive any steroids during the disease course and had no concomitant diseases like diabetes or heart disease. They could enroll about 34 of these patients and compared with 34 matched siblings who did not have SARS. Interestingly, insulin-dependent diabetes occurred during hospitalization in 20 out of 39. 6 continued to have diabetes at discharge. However, after 3 years of follow-up, only 2 had persistent diabetes. So it might suggest that the damage incurred by islet cells might not be permanent. It's mostly acute and probably transient. However, there were no reports of acute pancreatitis with SARS-CoV epidemic of 2002. Coming to our COVID-19 or SARS-CoV-2 epidemic and what evidence exists for beta cell damage. Increasing numbers of cases of pancreatitis are being reported in association with SARS-CoV-2. In a case series of 52 patients with acute COVID-19, 8 had evidence of pancreatic injury, abnormal elevation of lipase or amylase. This is just an example of multiple case reports. However, this elevation of pancreatic enzymes and evidence of pancreatic injury, whether it is an indirect result of severe systemic inflammation and multi-organ failure, or is it a direct cytopathic effect of the virus, it is still open for contemplation. Interestingly, more recently, a distinct subset of a moderate pancreatitis with pretty benign course is described from UK. When they identified a cohort of 5 SARS-CoV positive patients out of 35 cases of pancreatitis, these 5 patients did not have any other etiological factor associated with pancreatitis other than SARS-CoV positivity. All of them were male, overweight, had moderate abdominal pain, mildly elevated amylase, and some pancreatic or duodenal inflammation on CTs. Although all of them had persistently elevated inflammatory markers, none of them had evidence of multi-organ failure. And interestingly, 3 of them had new onset diabetes requiring insulin, with 2 of them had to go home on insulin. Though none of these reports prove causality, the direct effect, the cytopathic damage of the virus on pancreas cannot be ruled out. And it might seem that endocrine islet cells are particularly more vulnerable to the viral infection compared to exocrine cells. What about SARS-CoV-2 and new onset hypoglycemia? There have been multiple case series that increasingly describe hyperglycemia, new onset hyperglycemia with COVID-19 in adults without a previous history of diabetes, and it seems to significantly contribute to mortality and morbidity. How does it happen? It's most likely that the severe SARS-CoV infection resulting in cytokine storm leads to stress hyperglycemia resulting from insulin resistance. How much of it is being contributed by beta cell destruction and insulin deficiency is yet to be seen. What about new onset diabetes? During the early months of pandemic in Italy, 23% fewer annual cases of childhood diabetes were reported. However, those who were presenting had more severe DKA. Later, there's been a rise in reports of DKA and severe ketoacidosis at diagnosis coming from Germany as well as UK. A recent study from UK has also noted that the proportion of new onset type 1 diabetes in children and youth presenting in DKA has significantly gone higher. It was 51% this season compared to 38% in the previous year. What could be the underlying reasons for this increased phenomenon of increased DKA at presentation? It's most likely that the reduced access to primary and referral care services, especially during the early phases of lockdown and the pandemic, might have resulted in a delay in diagnosis. And even now, the parental fear of approaching the healthcare system could contribute to delay in diagnosis, resulting in increased severity at the time of presentation. And there's a possibility, definitely, that COVID-19 could act as an infectious trigger, decompensating and precipitating diabetes and DKA in patients with new onset type 1 diabetes. In a more recent multi-center study from UK has seen that there is an apparent increase in new onset type 1 diabetes with evidence of SARS-CoV-2 infection or exposure in some of these children. 70% of these children had DKA. 5 of 30 children tested were positive for SARS-CoV, either PCR or IgG, and 3 had severe DKA and refractory hypokalemia. However, the median A1C for all these children was 12.5%, indicating that COVID-19 might have been a trigger rather than an etiology on its own. So it was just a trigger precipitating a type 1 diabetes on its course. So this leaves us with few points to ponder. Could COVID-19 infection accelerate beta cell destruction and shorten the pre-diabetic phase in new onset diabetes? How does COVID-19 change the natural history of disease in those with pre-existing diabetes? Would COVID-19 induce hypoglycemia, remit on a long run, or lead to diabetes? To answer a few of these questions, a global registry has been opened in the name of COVID-IA project. They include with any patients with the phenotype of new onset diabetes defined by hyperglycemia, confirmed COVID, a negative history of diabetes, and a history of normal A1C. So coming back to our questions, can diabetes increase the risk of COVID-19 infection? Yes, most probably. Does underlying diabetes increase the morbidity and mortality from COVID-19? Absolutely, especially in older age groups. Can COVID-19 cause hyperglycemia and new onset diabetes? Hyperglycemia, yes, seems to be so. New onset diabetes is a question still to be answered. I'm going to close this session with this slide, trying to explain the possible pathophysiology. A pre-existing diabetes with poor glycemic control contributes to a hyperglycemic milieu that invites increased risk of SARS-CoV-2 infection. And COVID-19 infection in turn can increase hyperglycemia, either via causing stress hyperglycemia or maybe causing beta cell damage. And hyperglycemia ultimately leads to increased mortality and morbidity and poor outcome of COVID-19 in older adults. Whether this beta cell damage caused by COVID-19 leads to new onset type 1 diabetes or not, we are yet to see that. Thank you very much for your patient listening. I will be open to taking questions. Thank you.